We'll just kind of play along. So go ahead and take it away. We have two members here, so go ahead. The floor is yours.
Great, just 1 second. Let me get everything pulled up. Okay, welcome to the June 22nd, 2022 Medication Error Reduction in Workforce Committee. My name is Nicole Thibault, chairperson of the committee. Before we convene, I would like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I shared during our last meeting, I believe medication errors are the #1 patient safety issue facing pharmacy. Today, our committee will continue our education of the issues and receive various presentations that will explore the touch point between workforce issues and medication errors, as well as actions underway. This meeting is being conducted in a hybrid fashion. As included on the agenda, members are participating in 2 public locations, one in Sacramento, California, and a second location in Pasadena, California. As the chairperson, I am participating from the Pasadena location. Members of the public may participate in person at either of these locations or via Webex using the link provided on the agenda. Participants watching the webcast will only be able to observe the meeting. Information and instructions are posted on our website to join the Webex as well as the webcast. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allot 2 minutes to each individual providing comments. As public comments are taken, I intend to first accept public comment from those individuals attending in person at the Pasadena location. Vice Chair O will then assist with public comment from the Sacramento location, followed by those individuals participating via Webex. Moderator, would you please provide instructions?
Thank you, Madam Chair. Before we get started, I would like to remind committee members and staff who are not speaking to mute their microphones during today's meeting. If background noise is detected as a result of unmuted microphones, I will mute those microphones. There are members of the public in the audience and meeting minutes are being taken, so we ask members and staff to please identify yourselves before speaking. For the purposes of today's meeting, when the committee chair opens public comment, it sounded, Madam Chair, that you were going to take questions from Pasadena first. Was that correct? Okay, and then we'll move to the Sacramento location. And finally, for those joining us on Webex, we will be utilizing the Webex question and answer and hand raise features to facilitate public comment. When public comment is called, I will open the question and answer feature, which you will hear me refer to as the Q&A, and members of the public who wish to make a comment can click on the Q&A icon, type the word comment in the text box, and click on the send button. To utilize the hand raise feature, simply click on the hand icon next to your name to raise and lower your hand. Those who have called into the meeting can dial *3 to raise and lower their hand. These instructions will be displayed on the screen during public comment. After you've taken public comment from our Pasadena and Sacramento locations, I will call on those individuals requesting to comment through Webex. And now I return the floor back to you, Madam Chair.
Thank you so much. I would now like to take a roll call to establish a quorum. Members, as I call your name, please remember to open your line before speaking. Vice Chair O.
I'm here.
Hello. Jessica Crowley.
Licensee member, present.
Hi, welcome to our committee. Kula Koenig.
Public member, present.
And Jig Patel.
Jake is not attending today, Nicole.
Great, thank you so much. So now that we have established a quorum, I will now open the meeting for public comments for items not on the agenda. I would like to remind members of the public that you are not required to identify yourself, but may do so. I would also like to remind everyone that the board cannot take action on these items except to decide whether to place an item on a future agenda. Members, following review of the public comments for this agenda item, I will ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the board and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. We do not have any public members in Pasadena, so Vice Chair O, would you please facilitate public comment in the Sacramento location?
Any public comment in Sacramento? We do not have any public comment in Sacramento. Back to you, Chair Nicole.
Great, thank you so much. Moderator, we are ready for public comment from individuals participating via Webex.
Thank you, Madam Chair. I have opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen, or you may simply raise your hand. And I'll start with Lainey Dawn. Lainey, you should be able to unmute yourself. There you go.
All right,
We can hear you.
great. Thank you very much. My name is Dr. Lonnie Duong, and I'm a clinical pharmacist in California. As one of the team leads for the Pizza is Not Working movement, I want to thank the committee for moving up this meeting. As you've heard, pharmacy staff at large are coming forward with horrific stories of workplace conditions, which is why we're here. But they share these anonymously due to the very real intimidation tactics and fear of retaliation from corporate. A recent screenshot went viral when a pharmacist called in sick, and her manager's response was, quote, "You're really calling out today? I know you're aware that there is zero chance of finding someone today," end quote. The media has also reported pharmacists asking to leave or close the pharmacy that were actively in labor or having chest pain and were told to, quote, "wait for coverage." In most cases, coverage never arrived, and for one pharmacist, she died in her pharmacy waiting over 2 hours. This is unacceptable and inhumane, particularly for a profession that cares for others. We know from survey results from APHA and the board that these are not outliers or isolated problems. This is a system-wide corporate accountability problem. In Virginia, the board passed a bill, 54.1-3434, placing responsibility on the pharmacy permit holder rather than the supervising pharmacist, whose hands are often tied. It includes a short staffing reporting form and an anti-retaliation clause. Here in California, we're already hearing of commonplace SB 362 violations and have yet to hear of consequences, enforcement, or if there's whistleblower protections. I appreciate that these things take time, and I ask that this be made priority number one. The mission of the board is public safety. Protecting our pharmacy staff is protecting our public. I ask that protections for pharmacy staff from intimidation and retaliation be added to the next agenda and expedited, and that the
10
next meeting
seconds.
also be moved up to reflect the urgency of this crisis. Thank you so much for your time, and thank you for this committee.
Thank you so
All right.
much for your comment.
And the next request for comment is from Sean Bajorndal. Sean, you should be able to unmute yourself. There you go.
For having us today, and I want to reiterate what Lonnie just said with moving up this agenda. This is great. Sean Bjorndal, California pharmacist, and I just want to share what we shared in January. Again, I'm sorry, I'm here with Lonnie supporting the Pizza's Not Working movement. So last January, our team put together a survey that ran for 2 weeks. Now, this wasn't, we didn't have it. It was a small. I'm sorry. 2 questions were asked. Do you want to submit a complaint to your state board of pharmacy regarding your workplace conditions? And number 2, are you dissuaded from making such complaints due to fear of retaliation from your employer? Our data can't be validated like a formal scientific study, but we still wanted to understand what our colleagues felt or thought to see if we had any discussion points for future agendas. So, of those 1,081 survey responses, we filtered the data for requiring a pharmacy license. 972 of those were pharmacy licensed, where they're majority pharmacists. 87% said yes to wanting to submit a complaint. Of those that said yes, 89 said yes to question 2, where they feared the retaliation. Filtered again to California, 181 claimed to be located in California. 92% said yes to one, 91% of those that said yes to question two. So I followed up with a small sample size, but considering the data from questions 18, 21, 26, and 27 of the California Board of Pharmacy Workforce Survey, one can assume that this survey may be indicative of a larger population. So I want to follow up with the same request that Lonnie had for the whistleblower protection. Thank you so much.
Thank you, Sean.
All right, the next request for comment is from AC. AC, you should be able to unmute yourself. There you go.
Hello, members of the board. Thank you for allowing me to speak today. I'm a chain retail pharmacist in California, and I'm opting to comment anonymously due to fear of retaliation from my employer, which is also partly what I wanted to speak about. Within the past year, I've seen far too many medication errors, anywhere from patients receiving another patient's HIPAA information to prescriptions being filled incorrectly, or even patients receiving wrong vaccines. I have noticed these errors always happen at understaffed stores and because the staff is expected to do too many tasks at one time. It seems a large amount of medication errors in retail pharmacy happen not because of neglectful pharmacy staff, but because of the working conditions in retail pharmacy that have become commonplace and systemic. Companies are focused on quantity over quality to a dangerous degree that threatens patients' lives. Fortunately, we do have some laws in place in California, as have been mentioned, to improve working conditions, such as SB 1442 and the new SB 362. But those laws are only effective if corporations are held responsible for the safety of the pharmacies they own and patients they serve, and pharmacy staff reports violations, the latter of which isn't being done for two reasons. Staff are afraid of retaliation, as we said earlier, and two, staff don't feel that the board will or can do anything about the violations, even if a report is made. Improving working conditions in pharmacies should be a top priority for reducing medication errors and improving safety for patients. It seems that starts with having a way for pharmacy staff to report violations of these laws and unsafe working conditions that threaten patients' lives and safety without fear of retaliation, then with corporations being held directly and potentially publicly responsible for breaking pharmacy laws, as Walgreens was with the Arkansas Board of Pharmacy a few months ago. Safety of our patients is the top priority of pharmacists and technicians, but profits are the top priority of these corporations that unfortunately employ the pharmacists and technicians, and that needs to change.
10 seconds.
Honestly, the best time for these working conditions to change was several years ago, but the second best time is now. This can't wait any longer. Thank you.
Thank you for your comment.
All right, and that is the last of our requests for public comment. Madam Chair, shall I close the Q&A panel?
Yes, please.
Okay.
So members, we cannot take action on the public comment, but please let me know if there are any items you would like to include on a future agenda. Okay. Next, we're going to move on to agenda item 3, the approval of the January 27th, 2022 committee meeting minutes. Members, attachment 1 includes a copy of the draft minutes from the January 27th, 2022 meeting. As we begin, I will first ask for questions or comments on the draft minutes from the meeting. I would also entertain a motion if you believe such action is appropriate. Members at the Sacramento location, are there any questions or comments on the January 27th, 2022 draft minutes? As part of your comments, I ask that you identify yourself prior to making your comments or offering a motion.
Chair Thibault, this is Song from Sacramento. I make a motion to approve the minutes as drafted.
Thank you, Son.
Second.
Thank you.
This is Jessie, sorry.
Great, thank you. With a motion and second on the floor, I will now open the discussion for public comment on the January 27th, 2022 draft minutes. There are no public participants in the Pasadena location, so Vice Chair O, would you please facilitate public comment at the Sacramento location?
Any public comment in Sacramento? We do not have public comment in Sacramento. Chair Thibault?
Thank you. So moderator, we are ready for public comment from individuals participating via WebEx.
Thank you, Madam Chair. I've opened up the Q&A panel. If any member of the public would like to comment on the approval of the January 27th, 2022 committee meeting minutes, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment at this time. Madam Chair, shall I close the Q&A panel?
Yes, please. Thank you.
You're welcome.
With a motion and second and a chance for public comment, I will now take a roll call vote. Sung, how do you vote?
Yes.
Thank you. Jessica, how do you vote?
Yes.
And Kula, how do you vote?
Yes.
Great. And I also vote yes. Thank you. So now we can move on to agenda item 4. This is the presentation by the National Association of Boards of Pharmacy on its workforce task force report and national perspective of workforce-related issues, including discussion and consideration. Members, I would like to welcome Bill Cover, Associate Executive Director in the State Pharmacy Affairs with the National Association of Boards of Pharmacy. Mr. Cover, thank you for coming today. We look forward to learning about task force report, including the recommendations offered. Mr. Cover, the floor is yours.
Thank you, Chairperson Thurman. Yeah, there we go. Thank you for the opportunity to be here today before this committee. And hopefully one of the asks that was received by our association was to come and speak relative to some of the work and efforts that we have done as we support our member boards across the country around this very important subject. So with that, moving to the next slide. Again, the California Board of Pharmacy is a member of our association. Our association aligns with the public health protection mission of the California Board of Pharmacy, and so all of our activities are really designed for here in the state as well as across the other 53 jurisdictions to support your important work in protecting the citizens of California. And myself, being a former member of the Indiana Board of Pharmacy, I appreciate your efforts and what it takes to meet that mission. So with that, I'll move to the next slide, please. So relative to the task force that was convened in November of last year, which was in response to a resolution at our annual meeting in May of last year, in which directed the association by the full membership. Again, this is our annual meeting has full membership across all 54 jurisdictions, and a resolution came out of that meeting for us to have a task force focused on workplace safety and well-being. And this, again, this was convened in November, and I'm going to speak to the report that came out of that from that task force. First of all, I want to just talk to what was the charge of this task force. It's always important to know what are you supposed to be doing, and this was a group of individuals. I think you all have the actual report that details who was part of this task force. But again, we in all of these committees and task forces that we convene, we really work to have a very broad cross-section of state representation as part of this. But the task force charge was to examine where our pharmacy workplace safety, what are the concerns, as well as the well-being and what is the effects on patient safety. Also reviewing existing guidelines and objective tools that can help address some of these issues and make recommendations. Finally, amend, if necessary, the NABP Model State Pharmacy Act and model rules. to reflect some of the recommendations from this task force. So those were the three primary charges for the task force. If you could move to the next slide, please. So coming out of this task force, there were several recommendations. I'll just kind of walk through each of these. First of that being for NABP to collaborate with other organizations that, and specifically around, these are patient safety, medication safety organizations. The first, AHRQ, which is the Agency for Healthcare Research and Quality. PQA, which is Pharmacy Quality Alliance. And finally, ISMP, the Institute for Safe Medication Practices. I just wanted to make sure we had it on the record what those acronyms stood for the public. But as far as this working with these organizations specific to develop a standardized CQI program that we can provide to our member boards that and they can recommend to those licensees within their states that could detail, including but not limited to, training on how you can develop these type of CQI programs and how do you implement them in a pharmacy. And secondly, how do you monitor those CQI programs within your state to determine, are they being effective? Secondly, NABP to work with, again, the Agency for Healthcare Research and Quality to provide a platform, to obtain de-identified medication error data. Again, that can be shared with the boards of pharmacy as well as those that are regulated within those states. Also, for NABP to endorse the recommendations of the task force on safety-sensitive measures, to review medication errors, and to look at the creation of a medication safety training academy. That task force was also held last fall, prior to this one I'm speaking to in October, and primarily that committee really worked in kind of looking at the development of this safety training academy, which for the board and the public is really a way in which NABP can help serve the member boards through training of board members, compliance officers, and various at the state to understand and make sure that there's what CQI programs are, how can they be best implemented, as well as just culture and the looking at holistically at the facility, the conditions in which they work, those pharmacists and pharmacy technicians and interns are working, and so that's really what that training academy, and we're working as an organization to put that meeting together. So I think that will be something that will be developed through our foundation to support and be offered to the states in the near future. Going on, measures to review medication errors and again develop this. I'm sorry, I hit that on that. We'll move on to the next slide. Also, NABP would to endorse the APHA and NASPA, the Pharmacist Fundamental Responsibilities and Rights document. To date, there are a number of organizations that, relative to pharmacy practice, as well as a number of state boards of pharmacy that have also signed on, in support of this document that was that really talks about, not what only what is the responsibility of the entities in which they, in the practice settings, what are they responsible for, but what is the pharmacist's responsibilities and rights within that. So I think it's we felt as an organization is very to support and with that that message. Next, with NABP to collaborate with other organizations, such as impaired pharmacist programs, to emphasize, and the importance of really considering pharmacists and all those individuals that work within a pharmacy, their well-being, mental health, and all the things that occurred that were already a challenge prior to the COVID-19 pandemic, but that were just exacerbated over the past 2 years. Finally, the NABP to review our Model Act and consider, in that, consider amending the definition to incorporate errors, adverse events, missed errors, really kind of defining more of those, and mirror those used by CMS, or the Centers for Medicaid and Medicare Services. Also adding a provision relative to mandated break periods, as well as adding a provision for anti-retaliatory or whistleblower protections. So moving on to the next slide. I think it's important to note for this committee that the importance of this matter within our association. In our president that took over in May of this year, Reggie Dillard, who was the executive director of the Tennessee Board of Pharmacy for many years, is our current president, and his initiative is to really focus on a really comprehensive review of the current pharmacy regulatory environment. Also look at pharmacy education and others that impact patient safety, as well as I think there's really 3 key areas, and I think it ties into this committee's work, is looking at, are there barriers in existing statutes or regulations that limit patient access to medication and care? Are there ways to increase patient safety by enabling pharmacists to practice at the top of their education and training? Probably more pertinent, again, looking at extrinsic factors that foster unsafe working conditions and environments when patient delivery, and identified, again, by this working conditions task force, the workplace conditions task force that I just spoke to. So again, this will be, again, his ongoing initiative this year, and we'll be continue to look at this and working with other organizations on this important topic. Can we move to the next slide, please? The next few slides I just wanted to provide to the committee, and this is a compilation from a number of different sources relative to the boards that many states have produced guidance documents that are kind of the work product of meetings and in which they've really engaged with the industry, the regulated industry, and having some conversations, discussions, some of those not easy today, but really focusing on there are problems today, especially in community practice, as well as in other practice settings. But what can we focus on and work together on solving, some of these challenges? So again, some of coming out from state guidance documents, as well as other work. I believe APHA is going to be speaking here today as well. Some of this came out of a summit that they held that brought together a great cross section of representation to address this. But going through some of these, again, the promotion of a contingency plan for when pharmacies are understaffed relative to patient demand. Encourage PIC, or pharmacists in charge, or the manager to develop and implement use of a board pharmacy staffing report. Like several states have incorporated reporting forms, like if they feel like their pharmacy's understaffed at a particular time. Develop regulations related to CQI programs. We just kind of error reporting and just culture. Like I just discussed some of the coming out of the task force that we had. Allow for aggregation of medication error data that can be shared with boards, and again, that aligns with the task force recommendations. Review daily workflow report to identify pharmacies in need of assistance and route additional staff to support the locations. So again, some of these are the industry identifying within the ways in which they can help and support the pharmacies in their organization or their ownership. Encourage managers to utilize alternative methods to monitor individual pharmacists' work patterns to prevent burnout. And I think this is something that is continuing to go on, and I know APHA is going to talk to their well-being index, and I think it's critical and part of our work as an association is to also focus on this well-being and which is part not only in the practice of pharmacy but across health professions. If we can move to the next slide, please. Another suggested approach is analyze the workplace and well-being status of pharmacy teams within the states that have progressive and permissive pharmacist authority or regulation. Again, is there an impact to pharmacist workplace conditions if those regulations and give some ability for them to practice in a different manner, and what's the impact of that to those workplace conditions? Encourage organizational management to spend time within the pharmacy practice sites to really see it for themselves what their pharmacists, technicians, interns are facing on a day-to-day basis. Provide opportunities, appropriate opportunities for uninterrupted rest periods and meal breaks. And that was also, again, part of our task force recommendations. Delegate non-discretionary tasks to properly train pharmacy technicians or pharmacist interns. Report violations and or unsafe conditions to the Board of Pharmacy, as well as provide an option for patients to have their prescriptions delivered or shipped to their home for their convenience. Let patients know if the pharmacy is experiencing significant delays or cannot dispense prescriptions in a timely manner. And also adding outside staff to help maintain the conditions of the pharmacy, even as it relates to prevention of insanitary conditions. So again, these are again not these represent from a collaboration of different recommendations from pharmacy board guidance documents across the country, as well as of other organizations that have really engaged with the regulated industry and looking at. So wanted to bring some of these to this committee as you do your important work. But with that, the next slide. And I'm here, answer any questions the committee might have.
Thank you, Mr. Cover. I appreciate that many of the recommendations are outcome focused. Reflecting on some of the information we received during our last meeting from ISMP representatives, I agree that training on continuous quality improvement is important. During our last meeting, I was surprised to learn that pharmacy education may not address learning continuous improvement processes, which may result in some new practitioners not having training on how to implement such a process. Since I am in the Pasadena location, Vice Chair O, would you be able to facilitate the member comments in Sacramento?
Sure. Thank you, Chair Tebow. Kula?
So I just have a couple of questions. Is it just from what I've even heard in previous comments, it seems to me that a big issue is also just how many people we have in the workforce, how much we have for staff. Is that a correct assertion?
Yeah, I think that's something that, again, I was part of the APHA Workplace Summit, and that was definitely something that was brought up because it was the regulated, a lot of the licensees were at that meeting, and I think that's, as well as even the schools of pharmacy were represented there. So I think that some of what we're seeing today is, during the pandemic and some of the demands that came with the very important work that we did. I think that's the critical thing I want to say is the pharmacy profession really responded. But I think coming out of that, you have pharmacists or even pharmacy technicians, others that are really not advocating for individuals to go into the practice or advocating for those that are looking for work to consider being a pharmacy technician, which is an extremely important role in our pharmacies. And so I think that combined with the national labor shortage across all the industries, I think just compounded the impact of pharmacy. And I think that some of the things that came out of a lot of the well-being things that are being discussed is the impact of working in the community, not just in pharmacy, but in other health professions. It has not been easy. Those individuals are coming in, are sick. They have loved ones that they've lost especially in with the public health and the COVID-19 pandemic. So I think all of us have experienced, the difficulty of separation, loss, and the impact of how they interact with their pharmacies and staff was really dramatically different in many cases, and I think that took a toll, and so some that advocate for the profession previously or not, or they've gotten out of the practice altogether, and so I think to your question, yeah, that definitely is entering into this equation.
Yeah, so I guess kind of my follow-up thought, because I was listening to your presentation, is around, and maybe you're not the right entity to think about this, but some of the recommendations, just don't seem to address that. So around, like uninterrupted rest breaks, right? If you don't have enough staff, how does uninterrupted rest breaks or meal breaks, how does that happen? As again, I'm going off of hearing from some of the previous public comments that we've had at previous meetings around just there's no one to cover you, so to speak. So we can have, a safety training academy or things like that, which I think are good. But if one of the root causes is around staffing, that's just something that I'm just still trying to wrap my head around it. So it sounds like it's also a PR issue. It could be a pay issue. So those are just some of my thoughts as you were giving your presentation.
Thank you for that comment. I think that one of the things that's changed, and one of the things that I think from consumer standpoint is that as a profession, we were, and I think you continue to say, we were the most accessible healthcare practitioner in many communities. And so pharmacies were open, and available all the time. What we're seeing now with staffing challenges is that a lot of those hours are being reduced. And I think that intensifies the pressures on our pharmacies, as well as our consumers that are going in and finding that their pharmacy is closed or there's not staffing. But I think what I'm starting to see is organizations that are, doing where they're closing specific times during the middle of the day, and they're, making notice of that, so that the not initially it's going to be oh, I didn't realize someone's going to be there, but over time they understand and they begin to respect that those pharmacists and technicians, they need that downtime to be safe and providing that care. So I think that's what we're seeing in a number of organizations are again, just closing a specific time and providing notice. And again, I think that's not universal, but I'm starting to see that trend.
Thank you, Claude. Jesse?
Thank you so much for the presentation and all this information. There's a lot of good stuff in here. Kind of a follow-up to what Kulo was mentioning, just from the perspective of retail and having worked in Massachusetts as an intern and for several years in California as a pharmacist. I know it's technically not our jurisdiction regarding meal breaks and lunches and regular rest periods, but I can say from personal experience that I don't know any community pharmacist who actually takes their rest breaks. And if you talk to retail pharmacists, a lot of them will say that they don't actually want to because then they have to catch up on all of their the work that builds up in that period, which kind of ties into the staffing thing that we're talking about. Is even if you take that break, if you don't have enough staff to keep up with the work while you're gone, you end up having more work for you after that. So that's not really a question, but I do have several questions for you, so thank you so much for your patience as I go through them. You did mention just culture, and I know the presentation last time from ISMP mentioned it. Can you just remind us again what just culture actually means, just so we have a little bit more clarification on that?
Sure. So, thanks for that question. I can't verbatim to speak to the whole definition. I think there's probably a better, but I guess really, in short, it is when in looking at, especially around medication errors and quality issues, whether that relates to those that actually impact a patient or even near misses where things are caught through into that process, is looking at that in a way of really holistically as far as the practice site, not just saying, well, why did you allow that medication error to happen, and the whole responsibility being on that individual, but really a holistic approach of, is that environment a safe one? Is it being, do they have the tools, the resources, and the, in many cases, process flow or support to, really do that practice in a safe manner. So I think that's really the focus, and what that's about is really, if an error occurs, especially, or even, I know ISMP has a lot of tools where proactively you can assess a practice site for, meeting a lot of those safety standards, and so that you prevent, those errors from occurring. And so I hopefully that helped answer that question.
It does. Thank you. I was also wondering if you could provide a little bit more clarification. There was one portion that mentioned the definition of errors and near misses under Centers for Medicaid and Medicare Services. Can you provide some perspective on what their definition is versus what pharmacy practice views that definition as it is today?
That's a really good question. I think I'll have to pull that information and then can provide it back to this committee to give you that more detail, because I don't want to give you incomplete information. So I'd be happy to pull that together and send it to you all.
I can send that to you later too if it's helpful.
Sure.
And then I know the report mentions that specific data on medication errors from states is pretty limited. So you may not be able to answer this question, but I was just wondering if you have any information on a national level as to any patterns where medication errors occur. for example, in hospital settings versus community settings, and then getting into the nitty-gritty of, does it happen more at higher volume pharmacies? Does it happen more in lower income areas versus wealthy areas? Is there a trend for certain demographics, including race, maybe sexual orientation, or gender identity? Do you notice, or do you have any information on that?
I don't at this time. I think that's something that we can work, and again, as part of what the recommendations coming in collaboration with the organizations that I described that could provide a lot of that data. So I can certainly, we can reach out, and if you could provide some of that detail that you just stated, we can work with those organizations to provide that data.
Thank you. I appreciate
Absolutely.
it.
Sure.
Thank you, Jesse. I have a few questions for you, Mr. Coover. Thank you for coming. So I'm really glad to see those few slides back about those workforce suggestions. Interesting, an ABP understands staffing challenges. Obviously, that's everyone, everywhere, it seems like. So are you guys able to do any research on it, just to kind of work with like industrial engineer or whatever entities to try to understand why we have such staffing challenges to begin with? Is it just a lack of staffing? Because anecdotally, I don't think there's a shortage of pharmacists. There may be a shortage of technicians. So why are we having that issue? Is it just mainly financial motivation? Is there something else that's going on? What is underlying reasons? And how can we actually have a solution? We don't fully understand what's going on.
Yeah, I think that is part of the presidential initiative, and so we're going to be working towards is because we work a lot with AACP, which is with the colleges of pharmacy, and determining, we've over a number of years we've had this ebb and flow of especially around pharmacist staffing, where we were really short in the late 90s and early 2000s, and then a report came out, we're going to be overstaffed or too many pharmacists, and then so we go through a lot of this, but I think that again, the impact of the COVID-19 pandemic, along with some of the other factors that we really, as an association, as regulatory boards, they know some of those fundamental economics of pharmacy, unfortunately, are there as well. That impact really the economics that can, again, I think a number of individuals, especially pharmacists, technicians, others, they're making a decision in many cases with their feet, like do I want it to work in a high intensity, relative to that rate of pay, and so there is an economic piece they know that really boards, can enter into, but I think that's an impact as well, that we're seeing. But again, our President Dilliard will be looking at that, and as well can provide information in the coming year in working with the colleges and other to kind of help. We're at this situation today. What are some of the short-term things that can be done, and what are some of the things that we can focus on and over the long term? And I think some of that, in speaking with some representatives from the colleges, is, and I spoke to a little bit ago, is how do we get those within the profession to advocate for the very important mission of practicing especially in the community? How do we get back to that point where you want your son or daughter to go into I'm a pharmacist myself, to tell them you should be a pharmacist. It's, I think that's kind of that, turning that around as well.
So is NABP have any way to do any research? I think that looking at one pharmacy, you can't really get an answer. But if you look at 1,000 pharmacies, you may be able to get a more understanding of engineering the right amount of staffing that may be necessary for pharmacy to actually function properly. Granted, there are so many different sections of pharmacy. Is there a plan, or can there be a plan for NABP? Or I'm hoping if you can take that to NABP, just wondering if they can do any research on partnering with maybe College of Pharmacy and maybe retail chains or whoever, or independent pharmacies, in kind of understanding that dynamics of staffing issues that's going on, so that we know, like, this is the red line. Because, nurses has ratios, and I think that those are born out of protection for patients. So pharmacy, I think we're really held together by these hardworking pharmacists that are holding down the fort. And, are we able to come up with certain statistic number that actually objectively is more scientific based to say this is a red line, it's crossed, we cannot perform these functions anymore? Can there be anything like that? That's more national perspectives.
Yeah, I think that something that, we can work with, especially around ISMP and some of the other organizations that are, but I think, and you kind of alluded to it, that, there's so many variables within a practice setting, and I think there are tools today that can help evaluate a facility, but it is very specific in nature, and even specific to the individual that's managing that department. And I think that's where we see some challenges too, is some are in management roles of a department prior to them being ready, and managing, and that environment and those individuals they have. So it's, in some cases, it's not just how many you have, how well are they trained, and are they directed in a manner. So I think there's a lot of those variables that would have to go into that. And I think drawing a specific number might be very difficult, just because of all the variables involved. But I think it's important to research that more, as far as, what are those best practices, what are the things that can lead to better patient care, and really focus on that.
Thank you, Mr. Coover. I have a couple more questions. You mentioned on the slide staffing reporting form. Do you know the states that are doing that? If you could provide that to us.
Yeah, I can provide that.
Then, do you know any states that require like a medication error reporting to the state boards?
Yeah, I could also provide that list to you as well.
That would be very helpful.
Yeah.
Sorry, don't mean to add work. You're already
No.
here on your own to just provide us.
That's what we're here to support. You
really
all.
Appreciate it. Thank you.
So,
go ahead. Yeah, I have also Chair Tebow would like to ask.
Sorry. So piggybacking on the question that Sung just asked about med-air reporting requirements, I was curious if you're aware of any that, as part of the med-air reporting, includes staffing. Because I think that, that's part of what this committee is looking at is there a correlation, and what does that look like? And then the other thing that I would be curious about, do you happen to know if, based on, the CQI processes where staffing was identified as the root cause, if that actually resulted in any kinds of changes in the staffing, or was it maybe, not addressed, or maybe it wasn't identified, if that makes sense at all?
I think if I can maybe what I took from that was that not only, yeah, if you identify that as in the root cause, but in their corrective action plan, let's say that did they identify, how they work to resolve or improve that in meeting what was found. So we can also definitely work to find that information and provide the TO.
Thank you, Mr. Cooper. We didn't come here to try to give you homework, but thank you for. Thank you. Membership has its privileges. Thank you so much. Chair Tebow, I'll take it back to you.
Great, thank you so much. You all had all my questions. Vice Chair O and Sung, you took my thunder there at the end, but I think that was a lovely discussion. Thank you, everyone. Mr. Cover, as a public agency, the board accepts public comment for all items on the agenda. We will now open for comment from the public present at both the public meeting locations and via Webex. This provides members of the public an opportunity to comment on the information provided. As there is no public at Pasadena, Vice Chair O, would you please facilitate public comment at the Sacramento location?
Any public comment in Sacramento? No, doesn't seem like it.
Okay, thank you. Moderator, we are ready for public comment via Webex.
Thank you, Madam Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions, and I do see we have some hands raised already. So, Lainey Dawn, you should be able to unmute yourself.
Hi there, my name's Lonnie Duong, and I just first wanted to echo what a lot of the board members have said. So thank you for kind of highlighting some of the, some of the holes in the well-meaning recommendations that have been made by the NABP. I have a couple questions. One was, there was a survey done, I think it was by the board, that stratified their results by chain pharmacies and independent pharmacies. And it seemed that the results coming from the independent pharmacy sides were a little bit more positive, not as much burnout, higher percentages able to, complete all of their tasks safely. I'm wondering if maybe any independent pharmacies have been looked at that, sort of in a way of looking at, where are things working a little bit better and what can we take from what the pharmacies that are doing well into other areas that may need that help. Also, I want to thank the NABP for the presentation today with all of the great recommendations. I want to ask if they are prioritized, in any particular order. I will say that personally, I think the, pharmacist's well-being is of utmost importance and has the potential to kind of have the biggest impact. If we fix that thing, I think it will spread to everything else and help resolve a lot of other issues related to med safety and patient safety. The APHA Pharmacist Workplace and Wellbeing report
10 seconds.
mentioned that there's a 2-time increase of medication errors for pharmacists that are identified as a risk of high distress. So I'll leave it at that. Thank you.
All right, the next comment is from Sean Bajorndal. Sean, you should be able to unmute yourself.
Alrighty, thank you for allowing us to comment. Thank you, NABP and California Board again for this presentation. I just wanted, not a question, but I love this presentation just because I spent 10 years roughly in retail with 3 different big box chains, and it was back in 2016 when I left and had my burnout. But all of this rings true. I don't think I had any. I'm kind of embarrassed for my quality as a pharmacist. I might have been great. Like, my customers and patients might have loved me and followed me from store to store. But when I look back on my quality and my error rates, it was embarrassing due to the reasons why we're here today, just with the lack of staffing. And it didn't matter whether I was at a store or a pharmacy, billing 1,500 per week or 4,500 per week, the error rates were relatively the same just because of the amount of work you still had to do and the lack of staffing there. So I thank you again for this forum today, and thank you for the presentation from NAVP. I love it. Thank you.
Thank you, Sean. Thank you, Lonnie. Appreciate your comments today.
And our next comment is from Tim Griffenberg. Tim, you should be able to unmute yourself. Oh, Tim, you were unmuted briefly, but if you could try that one more time. There you go, you're unmuted.
I would just like to bring forth a very important factor that corporations do not allow you to list staffing on a prescription error report. So if you're referencing to the amount of errors that are occurred by staffing, the reports are erroneous and misleading because they do not accept that as any valid reason for mistake to be made. Thank you.
Thank you, Tim.
And our next comment is from Stephen Gray. And Stephen, you should be able to unmute yourself.
This is a long-standing concern with the Board of Pharmacy and definitely related to its public protection role and also to the profession regarding the stress that are on some pharmacists. And it's a complicated one. I don't know if the committee has had the benefit of actually receiving the wage and hour report, the wage and hour regulations that require California pharmacists to all be paid on an hourly basis and to receive rest breaks and meal breaks, unless they are either executive or administrative. I think that would be very helpful. It is not the case in most of the country. They are not hourly employees, they are exempt employees. And so I would suggest that the committee take a look at that. Again, also, if you haven't had a look at BPC, Business and Professions Code 800, that is a section that requires all judgments and settlements for errors, negligence, omissions, etc., to be reported to the Board of Pharmacy if it is $3,000 or more. So not just judgments by a court, but arbitration awards or any settlement reached with a patient or someone related to this. That, I think that's important. And I think it's also important to share that information with the pharmacists out there. Many of them didn't get that education in school to those particular things, and yet they are directly related to the some of the issues, the working conditions and so forth that are being discussed by this committee. So I would encourage you to ask for and distribute to the committee that information. Thank you.
Thank you, Stephen.
All right, this is a moderator and I see no further requests for comment. Madam Chair, shall I close the Q&A panel?
Yes, you can. Thank you.
Thank you.
All right, so moving on, our next agenda item, we're actually going to be going out of order, and we're going to go to agenda item 6. Oh, sorry. Perfect. We're going to be going to agenda item 6. However, before we do that, I need a little break. Would everyone be okay with a 10-minute break? Does that work for you in Sacramento?
Absolutely. Yes.
Awesome.
Thank you, Chair Tebow.
Is 10 minutes good? I'm not sure what your setup is there if you need more.
Sounds good. 10's
Okay.
good.
Thank you.
2:17. Okay.
Roll call. Hi everyone, are you back in Sacramento, ready to do roll call?
Sorry, we were not muted. We were muted. We are all back, Nicole.
And Chair Tebow, though, we should do a roll call on the record for the Webex.
Great, thank you, Eileen. So for roll call, Vice Chair O.
Here.
Thank you. Jessica Crowley.
Licensee member present.
Thank you. Kula Koenig.
Public member present.
Thank you. And I am here. Roll call is done. Quorum is established, and we can start with agenda item 6. So this is going to be a presentation by Nova Scotia College of Pharmacists on the Nova Scotia Workplace Conditions Strategic Work. Members, I am pleased to welcome Beverly Zwicker, CEO and Registrar with the Nova Scotia College of Pharmacists. We are looking forward to learning about the efforts underway by NSCP. Ms. Zwicker, the floor is yours.
Thank you very much. And it is a very real privilege for me to be speaking with you this evening. And it is evening in Nova Scotia. I realize it's the afternoon in California, but I'm pleased to do that. The issue of workplace conditions is a priority focus for the Nova Scotia College of Pharmacists. I don't think that's my slides, but that's okay. The Nova Scotia College of Pharmacists, as the regulator, our mandate is to govern the practice of pharmacy leading to optimal patient care. And that's important to know because that bar is higher than ensuring that pharmacies don't cause harm. It's higher than ensuring patients aren't being harmed by medication errors. We recognize that if we are in a state where we are seeing a rise in medication errors, that this is a downstream evidence that we are failing in our upstream mandate of ensuring that pharmacies are providing optimal care. And so it is out of an abundance of concern that workplace conditions are creating substantial risk to that mandate, that this has become our priority focus. And our concerns are supported by data and findings, very consistent with what has been found by NABP and APHA, including recently a survey conducted by a third-party organization of the workforce nationally that said 90% of Canadian pharmacists are at risk of burnout. 60% would say that when they are at work, they are not thinking about what they are doing. It's very automated. We have 70% of pharmacists that are saying they're going to make some sort of change with respect to their place of employment, with 40% saying they are considering leaving the profession. All of this is very concerning for the college. And so it's not that we needed additional information to support that this is something we need to prioritize, but I just wanted to flag that this is certainly a very real and consistent problem that we're experiencing in Canada, just as you are in the US. I don't know if you can advance the slide. Are my slides there? Because perhaps if they're not, that is okay. I will
Sorry,
just...
Bev, I think we're trying to work on to get that on there as well. So
Sure. I'll just keep going.
Keep going. Thank you.
And if you're able to, then jump in. So just to say that this work, actually, we began this work in 2018. Workplace conditions were challenging then. We were hearing certainly abundance of concern. We didn't have the same data with respect to burnout. And some of the more very concerning findings we're having now, but there was enough to say workplace conditions, they're not supporting the provision of optimal care. And so we began work to explore what is within our regulatory purview, our jurisdiction in terms of workplace conditions for us to address, recognizing that, there's a significant association responsibility with respect to, how is the workplace favorable. But when it crosses the line into affecting care, that was us. So we began working with an engineering firm just to explore we're getting that. So that is the background or paper. There's another document that is slides. If you're able to find that, there were 2 PDFs I sent. So we began working with the firm, and we conducted a literature review. And from the literature review, we were able to identify themes of issues that we then used as the basis for interviews with pharmacy practitioners in Nova Scotia to validate. And I'll talk about our findings on the literature review hopefully in a minute if the slides can be brought up. And having conducted, there we go, we're getting close, very close. If we can just write those, that would be great. So we conducted interviews with excellent Nova Scotia practitioners. So if you just advance me one, that would be perfect. Sure, and maybe one more then. And I might need you to go back, who's ever driving that. I appreciate your support and patience with us. So we conducted a literature review. We then took those findings, we validated them through interviews with pharmacy practitioners using a qualitative approach. We then took our findings, which really did validate that what we learned from the literature in terms of there being a linkage between pharmacy practitioners feeling overwhelmed and negative outcomes related to professional burnout and job dissatisfaction, diminished service quality and reduced offerings, and hence the increased risk for errors and omissions. That the literature was very clear that there is a link between the state of the pharmacy workforce and the quality of the practice that they provide and the risk of errors. So we then took those themes and we conducted interviews to determine whether or not the findings from the literature was at state present in Nova Scotia, and yes, indeed it was. And then from there, created a survey, a quantitative survey that we went out to all Nova Scotia just to verify that indeed was the case. We then used this to do some strategic work in 2022. I'm going to go back in just a moment to highlight that. I'll have you back up the slide in just a moment, but we conducted interviews with stakeholders as we began to explore what we could do to address our findings, and then validated as well this work with a pharmacy manager survey. So if you can just back up the slide a little bit, I just went in detail into what that, at a high level, just that background research that we've been conducting to support what we've been doing since 2019. From there, we developed a visual that we find very helpful in conceptualizing how this complicated matter of workplace conditions is being driven by a variety of factors, and what some of the system factors are that we can't address, what are the levers that we could address, and using this to support us in determining what is the most effective action we could take, understanding that there's so many factors at play. So we did that work. We then prioritized the factors according to what's the feasibility of us being able to impact that factor across the bottom, and what's the impact if we could address it, and anything that situated itself in that yes quadrant, high impact, high feasibility, was where we agreed we would focus our time. And out of that work, we have identified that staffing levels are the staffing levels created by business models. It is the primary factor that we should focus on in order to make a meaningful impact on current practice conditions, recognizing that there are many conditions, there are many factors at play, but this is the one that we would focus on. So that's our decision in April 2022, and now we're in the process of designing and implementing interventions. So with that high level overview, I'm just going to walk through just a little bit now. If you can go to bump ahead 2 slides, this one. So again, that literature review that we conducted, and I'm happy to provide that if anyone would like, that we had our engineering firm Davis Peer complete, established the clear linkage between professional burnout, job dissatisfaction, and how it can compound to negative system outcomes, such as an increased risk to patient safety. And I think that is probably without question. I think for us, the recent finding that said 60% of people are not thinking, 60% of practitioners are not thinking about what they're doing because they are their state of mind, either the busyness or their general state of burnout is very concerning. The themes coming out, if you advance, the themes coming out of that research that we then brought to pharmacy practitioners, the interviews, were focused on workload demand, accessibility of pharmacy professionals, that you're always on, pharmacy professionals are always available, that they are available to be interrupted, but it's a badge of honor that the profession has worn, and it has become the terms of engagement that the public has come to understand about how the public interacts with pharmacists. It's an at-the-counter, on-demand service. Scope of practice is also another theme that we explored in Nova Scotia and in other provinces in Canada. I don't know how it is in the US, but we've been working to enable pharmacists to use the full extent of their knowledge and skills in meeting the needs of their patients. And so their authority to be able to do a wide variety of activities consistent with drug therapy management, including prescribing, to adapt and to lead drug therapy management, is in place. That's created increased work. And so we recognize that this increased scope of practice is also a factor. Labor models was another theme, and staffing levels. And I guess I've already spoiled the outcome. You know where this is going, but those are the themes that we identified from our interviews. So if you want to advance 2 more slides, we conducted a validation survey, and this is what we determined, that 85% of participants indicated that workload levels were unsustainable. 71% said staffing levels were inadequate. 81% said they felt burnout. 76 said that the current pharmacy practice challenges resulted in reduced standard of care. Again, this is compelling for the regulator with a mandate to provide optimal care. And 75% said that the current pharmacy practice challenges are resulting in a risk to patient safety. So no further evidence is needed to say action was required. So fast forward then to, this was all, I should say fast forward, this was in the fall. In the spring, in March, our work then focused on what is the one factor, how can we better understand what's happening so that we can focus our work on one priority factor. Recognizing that there's 15 or 20 things that we could maybe move 1 inch down the field, that maybe our approach and our objectives would be better served if we could find what is that factor that if we focused on that, we could move this substantial ball maybe 50 or 100 yards down the field, and that would be more meaningful. And if that's the case, how do we look at all of these factors that we've identified and determine which of those we're going to focus on? So if you want to fast up to the picture, the visual, in looking at our findings from the I think it's 1 slide up, in looking at, it should look like a visual. No, I think it's 2 up then. There we go. So in looking at the factors that we identified from our literature review and our current state, and working with researchers and our systems engineers, what we were able to create was a visual that helps us better conceptualize what's happening. And we've grouped the factors into practice site conditions and HR capacity. So in practice site conditions, those are those factors that speak to the volume of work, the expected quality of work, the service culture that we've imposed on ourselves and that the public has of us, and the physical space in which the practice happens. So those are the practice site conditions. And on the other hand is the capacity to do that work. So that is the major levers in there. The major categories are the HR plan and budget of the pharmacy owners, the availability for the workforce in meeting the allotment of the pharmacy owner, the skill level of those that are hired, in the pharmacy, and then how they are used, and in particular, the fully utilizing pharmacy technicians for their in their scope to do administrative and technical activities. And what we realized was, or what we've certainly landed on, is that what we're experiencing is the result of practice site conditions and HR capacity not being balanced. There is more work to do than there is HR capacity to do the work. And that is leading to those red boxes. These are the categories of harm that we are saying, or patient safety risks that are a result of this out of balance that we currently have. We've got risk to patient safety, we've got burnout, job dissatisfaction, unmet patient expectations, unmet patient health needs, reduced service quality, and reduced service offerings. Before I just speak a little bit more about our next steps, I just wanted to highlight, we did recognize that there are external contributors that are impacting all of this, and that they are largely outside the direct control of the regulator, but it was important to be aware of them so that we can be mindful in whatever we do, that changes in these or work in these areas will also impact the balance of that scale. So we have some that are specifically related to work, like practice site conditions. So whatever the owner's business strategy is, some space constraints, the culture of pharmacy. I mean, these are large factors that really we don't have the ability to directly change. Targets and quotas, pharmacy growth, third-party insurance, there's a variety. And then on the HR side, recruitment challenges, retention challenges, access to training, pharmacy care, labor models. So they are external contributors that we might be able to influence, aren't necessarily something that we can directly by a rule change per se. And then at the bottom, we've also identified the larger system context, which is just the dynamic nature of the world that we live in that is also having an impact. Labor shortages, population growth, technology, the pandemic, I won't read them all, but they're there. And we highlighted those because as we continue, this is a journey, checking in on these to say, have there been any major significant changes in these that we need to be thinking about that would warrant us changing our strategy? So that's our visual, and we are going to use that to, as we continue in this work, to help us, again, explain and conceptualize what it is we're going to do to right the balance. If you want to proceed to the next frame, what we then did was we took those factors, and as I said, we did a prioritization work, looking at the appropriateness of a regulator to address the factor, dependencies. Are there other organizations or other stakeholders who are working on that factor? So it's maybe not as significant that we address it, or alternatively, we could help with some synergy, really magnify that work, or maybe there's work at play that's going to make it particularly difficult for us. We're kind of working in a headwind. And then also looking at alignment with other sectors. So those are the first three are really in terms of feasibility and impact. We were looking at those and where we'd place each of those factors on the grid. And then we also considered what assumptions and limitations are we making, and when making those assessments, and what are the unintended consequences. And so having worked through that, we brought together people from other industries, some strategists, doing our best to mitigate the risk of availability bias and anchoring bias, which is as individuals within the profession, we are at risk in our problem decision making of seeing what we are familiar with seeing, and not necessarily recognizing challenges or solutions that are that may also be at play because they're just not what we're familiar with. So we did bring in others to address those biases. And where we ended up, next slide, is, as I said at the beginning, we recognize that in the end, the recommended factor for us to focus on, again, with the intention that we would take 1 or 2 balls 50 yards down the field rather than try to move 20 of them 1 yard, is staffing levels and mix. So that includes total staffing hours. It includes the mix, pharmacists versus pharmacy technicians and what combination. And in addressing staffing levels and mix, this would also address factors of not enough overlap, not enough handover time, pharmacists working alone. So these are other factors that, by addressing staffing levels and mix, also would impact these factors. So we just highlighted that. So staffing levels and mix, and the other primary factor, business model misalignment. And so again, that is pharmacy owners maintaining, this is all the staffing that a pharmacy needs, and the pharmacist saying we do not have the staffing that we need, and the evidence of that. We would say one of the factors at play here is that there's a workload centered on volume versus quality. We talked about understandable a business focus of return on investment, thinking of staffing hours in terms of profit, whereas a regulator, we look at staffing hours with a return on quality of care. So we've got 2 different focuses. In the end, if you advance to the next, we've said our agreed upon focus will be staffing levels established by business staffing models. And this addresses the interconnectedness of the 2. And so now we are engaged in the work of identifying an intervention that will achieve our revised objective, which is the next slide, of staffing levels are not a detriment to the public receiving quality of care. So that is, our previous objective was that the pharmacy practice environment optimizes the quality of care, and we've refined it, that staffing levels are not a detriment to the public receiving quality pharmacy care. That may be the last slide you have. I have 2 new slides were just provided by my engineering firm today, but I can just speak to them. Where we are at currently is they are looking at other industries to explore what interventions we could consider. And there's 2 primary areas where we have interventions on in our menu, if you will. One is a staffing formula that would be somewhat, would be much more, they call it elegant, I would say sophisticated, in considering the various known factors, and I say known in terms of industrial engineering and system engineering, that need to be contemplated when determining how much time is required, and in consideration of who is able to perform that work, what hours are needed, considering factors such as interruptions and the need for downtime, which I expect aren't necessarily being used in more of the corporate business models when they're thinking about staffing needs. And they're working with individuals in transportation, so trucking and airlines. They have done work in this area just to explore what they have done. And in healthcare, nursing, long-term care, medical residents, there's been work done by a variety of other stakeholders in how do you determine what is the staffing complement that you need. So they're at work identifying what those possible interventions could be, and then how we could use those if we so chose for our strategy. They're also looking at business model misalignment, and in particular looking again at the how we can address that pharmacy owners are making decisions that don't align, or with respect to staffing, that don't align with what the pharmacists are saying and staff. On this one, I just want to flag, in the short term, we have a requirement in Nova Scotia that pharmacy managers ensure that the staffing plan is commensurate with the needs, the patient needs of the pharmacy. And we are having some errors that we've been able to, because the staff have been willing to say we've had staffing issues that are contributing to it. And we've gone to the owners and managers to say, show proof, show us proof of how you have ensured that this regulatory requirement has been met. So it's a different approach from proving that they haven't, putting the onus on the regulator to prove that they haven't met staffing requirements. You show us proof that you have. Show us, for example, including how you have obtained feedback from staff that assures you of this, and in particular the pharmacy managers. So that's a new short-term strategy that we're hoping to use to help create a heightened awareness in their need to meet this requirement, but we're certainly not relying on that. Other industries that we're looking to and looking for interventions around the misalignment factor are the construction industry, and what they're doing with respect to near misses and incidents, food safety, and also the accommodations industry, Airbnb and Amazon. So I'm not sure they put those on the slide. I can't speak any more to that. They're doing the work. But our plan, our next steps is we're in the next few weeks, they are going to do a presentation to the college, and we are going to be inviting health economists, legal, some strategists that we have to hear their presentation on here are possible interventions. This is what this could look like, with the objective of flagging any that are non-starters for us, that we say, you know, we won't do that, shortlisting, and then doing a larger workshop probably towards the end of July, where we will work through, dig into 2 interventions to say this is how we could do this, and again bringing in that outside expertise to explore what the design of that intervention would look like, what factors we would need to consider. Our goal is that we will be ready with a detailed, we'll have selected at least 1 intervention, maybe more, maybe 2, but we're hoping again to really do a very focused, heavy lean on 1 by the August, September to move forward. I just a couple final comments I'd like to make, because I have had the privilege of listening to the conversations up until this point. And I know there's a lot of interest in CQI programs, and we are very supportive of CQI programs in Nova Scotia. We've had, we were the first province in Canada to establish a requirement for pharmacies to be engaged in CQI. We actually work with David Brushwood from Florida, and you may be familiar with him. He's a strong asset you have in the United States around CQI programs. And we're a believer in it, but the potential for CQI to be effective really requires a minimum workplace conditions that we would say don't currently exist. You need to be able to action plans to improve identified areas, deficiencies. And if you don't have the staffing, we would say that the car's in the ditch, the wheels are off the car. CQI is helpful once the car is on the road, to navigate a better course, to help it run better. But the car's in the ditch, we got to get the car back on the road. So that's my comment. We've had it in place since 2011, and I have to say, and we've been diligent. We go in, we inspect, we make sure they're engaged, that they're reporting errors, that they're learning, they're doing quarterly meetings. None of that has mitigated the fact that we have pharmacies with inadequate staffing and that they're overwhelmed, burdened, and burnt out. So I just wanted to flag that. The other thing I wanted to mention is we recognize that in working towards staffing levels, we do have a workforce issue that we are concerned about. Certainly, if the 40% don't hang on and decide to leave, and in a democratic society, people are free to choose to leave. We can't require people to stay. We could have a real pharmacist shortage. What we would say then is a staffing formula that says A plus B plus C plus D equals E. If you can't meet E because people aren't there, then you're going to have to adjust A, B, C, or D. I realize that's very simplistic, but in the end, the equation needs to work because patient safety can't be the outcome. Compromised patient safety can't be the outcome. If A plus B plus C plus D equals E is the formula that's needed for patient safety, that formula needs to be made to work. I think that's what I want to say. Finally, with respect to what we're expecting, and I don't want to presuppose that we're going to do a staffing model. There's reasons why it'd be really attractive for us. If for no other reason, it would be a strong countermeasure to the primary defense, if you will, of owners that we have a model. We've used engineers and this is what we need. This is our counter to we've used engineers and this is what you need. And actually, we have the stick of the regulations to ensure you do that. We would be looking to establish a floor. That hard red line, you don't go below, while still requiring them to meet the outcome that they have enough to meet the needs of the pharmacy. So our expectation is you probably need more than this. This is just the floor so that we can definitively say you're offside. We do have some unique opportunities with respect to that in Nova Scotia, and I was interested in the comments that have been made here today about the same observations. I can't remember who raised them, that a lot of our concerning workplaces are in pharmacies that are owned by corporates. Our independently owned pharmacies are less of a concern. In Nova Scotia, our provincial association actually has had an initiative underway for several years called Prescription to Thrive, and they've been working primarily with independent pharmacies. They have now begun to work with some of the corporately owned pharmacies to identify what does providing quality care require, how could they rework their workflow processes, and there have been learnings that they have themselves used and brought to pharmacies who are interested. As a regulator, we have not been involved in that work, but I say all that to say they are very interested in cooperating with any work that we would be doing in determining what, measuring times, if you will, and determining what's required in order to meet the standard of care with respect to general practice. I've talked a lot. I apologize. I hope you've been able to follow, and I'm happy to answer any questions, address confusion that I may have created for you.
Thank you, Ms. Wicker. I'm looking forward to learning more about the strategic work you will be evaluating related to staffing levels and mix, as well as business model misalignment. Members, as we open up for our comments, I would appreciate your thoughts about the utility of performing similar research in California as one of the potential outcomes for our committee to offer as a recommendation to the board. Vice Chair O, could I ask you to help facilitate member comments in Sacramento?
Absolutely. Thank you so much, Bev. I really appreciate you coming on here. Before I say, just wanted to check with Eileen and Ann. Could you just kind of tell us if we were to try to go down the road of trying to do our research first, is it practical, possible? How would we do about it? And if so, can I make a motion to do such a thing today? I just wanted to check with you, Eileen, because agendizing thing is
So you're talking about doing, this is Eileen, just to do a similar analysis.
Right. I would like to make a motion that gives the EO and the president ability to solicit and try to engage in research project to demonstrate staffing level similar to what the NSCP, Nova Scotia College of Pharmacists are doing.
That's something, one, I don't think you would need to do it as a motion. I think you could always do it as, staff working on additional things. But if you wanted to make that motion, I think you could. But I don't know if you necessarily need to do it. It could be a direction to staff to look at some of those options.
Yeah, I think just like a practical reality is, unless we found someone to do it for free, we're going to have to evaluate what that impact would be to our budget as well. But I'm not saying that as it's just like just something for us to consider as part of a decision, and maybe allowing us just a little bit of time to try to think that through and see whether or not our budget could absorb it, or what we could do to try to find funding, or maybe some of the schools of pharmacy would maybe step forward or something. I don't know.
Okay. Okay, with that, I'm gonna open up for Kula. No comments? Okay, Jesse?
Thank you so much for presenting today. This was very useful. Some of your findings are similar to the workforce survey results that came out from the board previously. A couple of things of note that I just found a little interesting. So you discussed staffing levels and mix, and I think that's a really key component. So there is definitely a difference between having a technician with years and years of experience versus a new technician. So just because you have a technician in a pharmacy doesn't necessarily mean that you have the supportive staff that you really need to provide quality patient care. Same goes for having a scheduled clerk versus if you're working alone in a pharmacy and you have someone who's not necessarily a pharmacy personnel but is cross-trained. They're not going to be as supportive to the functions within a pharmacy as, say, someone who has years of experience in a pharmacy. I also find your research in the staffing model very interesting as well. I know most corporate pharmacies anyway use a formula for staffing that is solely dependent on the quantity of prescriptions sold in a pharmacy, so it doesn't account for prescriptions that were processed and the labor going into that were never actually picked up. It also doesn't account for patient care services and how labor intensive they are. For example, processing any vaccinations, all of the billing goes through the pharmacy versus in medical offices, they have different personnel to do the processing and billing for them. Also just the time it takes to administer vaccinations, or if you're providing patient care services like furnishing birth control or naloxone, those consultations take a substantial amount of time, and none of that is accounted for in staffing models in corporate pharmacies as it exists today. So just wanted to kind of make that note. I did have a question. I know you mentioned the expansion of technician roles, and I apologize if I had missed it, but my question for you is whether your research found a correlation between the expansion of technician roles and its impact on pharmacist burnout.
Yeah, so I don't recall there being, I don't recall that being a finding that came out of our review. It may be something that's being looked at now. We didn't find any studies, or at least in the review that they conducted for us, I don't remember that being a finding. I also, just want to, while I have the mic, clarify, the staffing model is one of the options. So we haven't definitively determined that is what we're doing. It's certainly, it's high on the list, and I feel confident we probably will, but before you do any motions to say we're going to do what Nova Scotia does, perhaps just wait and see where that ends up. And also, I'm happy to share whatever we have with you if we go that way, or if you want to somehow piggyback on to help make it a more affordable or helpful process, or just share what we've learned. Happy to do that. I also recognize that I failed to mention one other intervention in the business alignment that we're contemplating, and it's an important one. It's probably the most, if the two are neck and neck, staffing models, the other one going neck and neck in terms of what we might do is enabling the public to better assess the quality of care and have public accountability, public rating systems. Having them, informing them about what quality care looks like, what they should expect, and rating the pharmacy, and let that motivate, given the importance of reputation to many corporate pharmacy owners, ratings about the quality of the counseling they've received, about the amount of time that the pharmacist spent with them gathering information and understanding their, what it is they're hoping to achieve through their from their drug therapy, and how they're doing along those lines. I don't think the public generally even understands that's what they should expect. So I just wanted to flag that staffing levels isn't the only intervention we're considering, that there is another contender. But I really appreciate your comment that, and it's what we believe as well, that the current models being used by corporate owners don't necessarily have the sophistication that's needed to establish staffing levels in consideration of some significant factors beyond what's a prescription volume, and that's what we'd be doing looking to do.
Thank you. The last comment or question I kind of have, I'm not really sure if this is for the presenter or just the board in general, but one of the things that also stuck out to me was the discussion of service culture and the expectation from patients that pharmacists should be available 24/7 at all times and stop what they're doing to assist them. So I wonder if there's any way in which we can look further into addressing service culture. I don't really know exactly what that would look like, but I thought that might be a useful thing to look into.
Thank you so much, Jesse. Oh, go ahead, Beth.
I was just going to comment, there's been a lot of discussion on that. And so when we were factoring that, we recognized that there's actually a number of other stakeholders that have flagged that and are interested in that. And I don't know what you're seeing in the US, but in Canada, the need to rethink what the design of the pharmacy is in terms of the care that's now being provided is something that is actually being actioned by some of the pharmacy owners. You're seeing them create physical plants that look differently, that have distribution in one part and a pharmacist or in the other, clinical service area, if you will. Or separating them to a place where they can't be interrupted. So necessity is the mother of invention, and I think where the need, how this is playing out, our observation is that this factor is a recognized need broadly across many stakeholders and maybe already being addressed. But I can't speak to what's happening in the US, but it may be something that you could explore as well, and maybe leverage, or not leverage, or at least add weight to.
Yeah, so member Koenig here, so that just kind of also made me think along those lines about thinking if you're going to go to a restaurant, you make a reservation, right? Or what if they were like open, this is like, I don't know, open hours, like times where any walk-ins, right? I don't know the feasibility of this, but then there's also set times where there's like reservations or checking in or whatever, so that could also help with staffing and quality control. So after you said that, I just started to think about some of the practical things that could be done. Not sure, but yeah.
Yeah.
The appointments.
I mean, I think we travel here a lot at the board members, and it just reminds me, I was traveling and the flight was delayed, and they just announced the pilots are timed out. And, when the pilots are timed out, they're timed out. There's nothing else you can do. They're based on probably some scientific engineering research that shows that once you pass certain hours, your body just naturally diminishes its ability to do something or whatever it may be. I hope pilots don't yell at me here. Same thing probably with flight attendants and nurses. I think we've gone too long here with just dumping everything on pharmacists to be able to somehow deal with it. So hopefully we will find some ways to provide those red lines. And Bev, thank you for your research. It's really, well, not, the board's research.
Yes,
Appreciate
yes.
it. And thank you for coming. I just hope that you can continue to have a dialogue with us here. I know we are going along with this for hopefully a little while, and so it looks like yours is continuing on through 23. So hopefully we will keep up with you and let us know what's going on.
We will certainly reach back and let you know what we decide for an intervention and what our plans are, and happy to support and assist or provide information in any way that's helpful, and share whatever our experiences are as we go along. We're just looking to take the next step so we can see further. I'll leave you with this one last thought that's been bothering me, and that is a quote I read that delaying action serves the oppressor, not the oppressed. And that, and thinking about great is the enemy of good. Really, it's can't delay taking action any longer while we try to find the perfect solution. It's just there's many good things to do. Let's start doing something.
Thank you, Bev. Anne has something to say as well.
So, hi, Bev. This is Anne. I have a quick question. You mentioned that the report will be released to the college. Is that a public meeting that people can attend virtually to listen in?
You mean the no, the upcoming one where we're the presentation on the various options. That's not to say that I wouldn't be opposed to inviting you or someone from your board if they want to participate virtually.
Okay, thank you.
Okay.
Thank you, Bev.
Okay.
Really appreciate it. Hopefully you can stay around a little bit longer. Nicole, Chair Tebow, it's back to you. Thank you.
Thanks.
Thank you so much. Next, we're going to move on to public comment. As there is no one in Pasadena, Vice Chair O, could you facilitate public comment in Sacramento?
We also have no longer any public in the public, so we can go to Webex.
Perfect. Moderator, if you could please, we're ready for public comment from individuals via Webex.
Thank you, Madam Chair. I've opened up the Q&A panel, and if any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. Just a reminder, we do have a 2-minute time limit for the sake of time, and I do see requests for public comments, starting with Lonnie Dawn. Lonnie, you should be able to unmute yourself.
Hi again, thank you so much. I just wanted to thank you for this presentation. It was so insightful. I'm energized for kind of the possibilities ahead for California. I wanted to sort of tack onto what you were saying about, for example, one of the strategies was to put the onus on the corporation to provide documentation that current staffing is adequate versus the opposite. And, including hearing from, employees, pharmacy staff. That's one example where I still feel that it's important to, protect pharmacy staff from potential intimidation or retaliation for ideas like this to work. Because as it is, pharmacists already don't feel, don't feel safe in freely expressing, their concerns. And, going back to your chart about, sort of moving a couple balls 50 yards down the line versus many, just inches, looking at strategies with high impact and high feasibility goals,
Mhm.
I wanted to highlight to the board, for example, maybe enforcing existing laws that we have, either more visibly or more assertively. SB 362 is a great example. SB 1442 is huge. No pharmacist left behind. We know for a fact that that's happening almost on a weekly, if not daily basis across the state. But pharmacists aren't reporting because of fear of retaliation. So I just wanted to highlight that having that component might really
Seconds.
help, all of these other recommendations really blossom and, kind of be at their maximum effectiveness.
All right, and that was 2 minutes, so we're going on to Tim Griffenberg. Tim, you should be able to mute yourself.
Yes. Thank you, Bev, and thank you and your organization for the research that you've done. And I think you've really brought to light and emphasized the importance of staffing. Unfortunately, we have, what would be, desired in an ideal world, and then we have reality on the other end. And we seem to be miles and miles apart, and moving further in the retail industry, is that we just can't get the employers to even provide minimum staffing. They're not even compliant with the current regulations that we have adopted. And that, it's a sad scenario, and it becomes more and more apparent that we have to have some type of enforcement to get compliance, just to get minimum standards. And then once we accomplish those minimum standards, we can, work to achieve, greater excellence in standards of practice and for the patient, and provide better patient safety. So what we really need to do is we need to adopt some type of a structure to either fine or penalize companies that ignore or violate policies that we already have in existence. Thank you.
All right. And the next request for comment is from Linda. Linda, you should be able to unmute yourself.
Wanted to comment as someone who's been in the pharmacy profession also for a long time on both enforcement side and on operations side. I've owned my own pharmacy. I've run a chain of pharmacies. And there's some salient points our last presenter made that she touched upon, but I want to highlight. Pharmacy is an interesting business model. It's one where the economic equation is fixed. So when you're a pharmacy and you're signing up to become a pharmacy, to accept insurance contracts, it's an all or none prospect. You don't get to negotiate those terms. And you also don't get to negotiate the terms with your pricing either. So you're talking about two items of the equation from the cost of doing a pharmacy that are already fixed. So when you think about it from a business, what can you control is you either increase volume or you decrease labor costs. And that's why this has been a decades-long issue of working conditions. These are for-profit businesses that we're talking about. And so when they're talking about their, IPO shareholders and their CEOs, they're trying to go for that bottom line. And what's safe for the public and what's safe for the employees is not always going to trump what's in the interest of the stakeholders. To put it in perspective, last year for the annual salary for CVS's CEO was reported a total compensation of $20.3 million. So, when we talk about the rising increased costs of healthcare, it's not because pharmacies are charging more. It's not because pharmacists are getting paid more. And to use President O's analogy about airline, pilots, right? If the cost goes up of jet fuel, or because there's a shortage in pilots, they have to pay pilots more, they increase the price to the consumer. The cost of airline tickets goes up, as we've seen very recently. But in a pharmacy, that's not an option. We can't charge more for our prescriptions. It's also one of the few professions where we give away our professional knowledge for free. If you consult an attorney, legal counsel, they're charging you, per 15 minutes of their time for that professional knowledge. Nothing.
10 seconds.
For pharmacists, we basically give that away, and we're getting paid cents on the dollar for the prescriptions that we do fill. Thank you very much for your consideration.
All right, this is the moderator, and that is the end of requests for comment. Shall I close the Q&A panel?
Yes, please. And thank you everyone for your comments. All right, Ms. Wicker, thank you again for your presentation. We will continue to monitor the efforts undertaken by NSCPs and would love to have you back to present findings in the future. We are going to move backwards to agenda item 5. I wanted to check in with the board members and everyone in Sacramento. Do you want to continue going or did you need a break first?
We're okay, but Nicole, if you need a break, please let us know.
I'm okay. Debbie's okay. All right, we're gonna keep going then. I just wanted to check in. All right, so now we are on to agenda item 5. This is the presentation by American Pharmacists Association on the Well-Being Index, Pharmacists' Fundamental Responsibilities and Rights, and survey results. Members, as you may recall, during our last meeting, received a brief overview of the Well-Being Index and noted that among issues raised as indicators that pharmacists identified as being at risk of high distress are, among other things, at a twofold higher risk of medication errors. As part of our discussion on this topic at that time, members requested a presentation from the American Pharmacists Association on the Well-Being Index, as well as other efforts underway by the association. I would like to introduce April Shaughnessy, APHA Well-Being Initiative Project Manager.
Hi, everyone. Thank you very much for inviting me here today to speak with you all and share highlights of work that APHA has been doing in the recent years. Next slide, please. We'd like to think that pharmacist well-being and issues concerning workplace are a new thing brought about by the pandemic, but they're not. As you'll see by this article, it was actually published in APHA's journal back in 1982. And it defined really pharmacist well-being that we can tell for the first time and burnout in pharmacy. And then some of you might recall, I know there were a couple folks from the public listening in that would probably remember this. Back in 1995, the California Pharmacists Association, I believe, had what they called then an employee committee or task force on employee pharmacist work issues. And CPHA released a model contract that could be used by employers and employees with the goal to address some of the workplace issues confronting community practice at the time. So these are not new issues, but they've been obviously before the pandemic, but the pandemic has really magnified the issues and concerns. And as a result of this magnification, along with our stories in consumer press, both nationally and at different big cities and newspapers and TV reports, many of the state boards of pharmacy, pharmacy associations, employers, and pharmacists themselves are now prioritizing these issues and trying to explore ways to address them and make real change. The next slide, please. So as we talked about the Well-Being Index for Pharmacy Personnel, in 2019, APHA partnered with Mayo Clinic to bring the Well-Being Index tool that had been used by physicians and nurses to pharmacy. Next slide, please. And so the same basic well-being index is used for pharmacists and pharmacy personnel. And there's a couple of extra questions that APHA has added. But so what is it? It's an online assessment tool. It's not a survey. It's an online assessment tool to measure the dimensions of distress and well-being in the assessor. The well-being index is anonymous. So no one, not even the company that administers the well-being index, has access to an individual's assessor's response to the 9 questions or to their final reports and scores. And we know that that's really important, as others have talked about, pharmacists' fear of divulging some information. The Wellbeing Index is open to all pharmacy personnel across all practice settings. It's free. You don't have to be an APHA member to use it. And we really hope that folks will use it and it's promoted. We've noticed that a few state boards are promoting the tool for use by pharmacy personnel in their state. So next slide, please. So after someone assesses, they get this report, and it's dashboards for each of the 9 questions that are asked. And it tells you what your scores are. And then at the top, you'll see that this assessment, which happens to be mine from a couple of years back, how I'm doing compared to others who have taken the well-being index for pharmacy personnel. So this said I was above 90% of all other pharmacists that had taken this. Was probably a good day. The really important thing with this is that you can assess as many times as a person wants. You can schedule emails or texts to alert you at different intervals that say, hey, it's time to check your well-being through the well-being index, and track that progress over time. You might notice, a little bit of an increase, or your scores going up or your scores going down, and track that back to something that happened in your lifetime at that particular point in time. So maybe it was an event at work. Maybe it was a personal event. Maybe you added some well-being type activities, exercise, or some other stress reduction things. And you might be able to see that in the well-being index, in your well-being index scores, if you assess on a monthly or quarterly basis. Next slide, please. So when you finish, you'll get prompted to some resources that match the areas in the well-being index that you might be of concern for you as an assessor. So those will get pointed out to you, but you can access any of the resource buckets, I like to call them, but of the 9 dimensions, you can access any of those resources at any time. And open to all assessors to use those. The resources are developed by Mayo Clinic. Some are APHA, and some are from other sources that deal with well-being and stress reduction. Next slide, please. So this has been talked about a little bit already today, but there is a measure in the well-being index that I am able to get, because I cannot see individual scores or reports, but in the aggregate, it tells me a percentage of individuals whose scores indicate that they're at risk for high distress. It doesn't say that they are in high distress, but they are at risk for high distress. And so, and we define that as the distress percent. And I'll share some of those with you in the next couple slides. But the important measure of this distress percent is the Mayo researchers found that when someone is at risk of high distress, they're also at risk for consequences, negative consequences. And those are listed here. These are not to say that they have these things or are doing these things, but they're at risk for these happening. And one of them we talked about maybe why there's staffing issues in pharmacies. Well, if someone is at risk for high distress, they're also at a 2.5-fold increase, higher risk of intent to leave their position. So that's an interesting fact given the discussion that's happened earlier today. And then that someone also mentioned they're at risk for a 2-fold higher risk of medication errors. It's not to say that these folks are committing a 2-fold increase in medication errors. They're just at risk for this. So we have to be really careful how we couch these terms. And as of the end of May, the overall distress percent, so everyone who has used this tool as a first-time assessment or in a reassessment, it was at 32%. So that means 32% of the assessors were at risk for high distress. It's really important that number can't be extrapolated throughout the whole profession. This just indicates what's happening for those who have used the well-being index to assess. And you look at it and say, okay, 32%, okay, 32% are at risk. Maybe that's not a big deal. But then when you look back at the negative outcomes that could occur if you're at high distress, it is an important number to pay attention to. through the Wellbeing Index. Next slide, please. This just gives you a little snapshot in time as of the end of May for student pharmacists, pharmacists, and pharmacy technicians. The top number is national, the bottom number is California specific. California is much higher than the national. In pharmacists, it's a few points lower. We also have here the all national assessors, not just pharmacists, but all national assessors, again, was at 32%. And for California is at 29, a little over 29%. So similar in numbers in that respect. But this is a snapshot in time. I could pull it today and these could be different numbers because people can assess and reassess every single day. So it does fluctuate. I tried to pull data, as we'll see in a couple slides here, on the same day each month so that they're a little bit apples to apples. Next slide, please. This one is just for pharmacists, based on the top 4 practice settings. We offer pharmacists to put in a whole slew of practice settings, but these tend to give us the best numbers and the most people are in these practice settings. The top number in the bubble is the national number, and the number below pertains to California directly. So does this mean that California pharmacists are less stressed than nationally? It just means that the folks who use this tool to assess, say community chain, 39% of them were at risk of high distress. It doesn't mean that there aren't more than that. It just means those who use this tool to assess, that's what this number represents. So again, can't extrapolate this across the profession. But over time, you can see these numbers fluctuate and wonder what is going on. We kind of saw an increase during the early parts of the pandemic, and then it decreased more recently. And they're not wild swings. They go up and down by tenths of a percent or maybe a percentage point. Next slide, please. This is a sample of one slide in a report that's probably led me here today. We provide a monthly report to every state pharmacy association by district. So California is in District 8. There are a slide similar to this for each state in that district, and then there's a number of charts that show the other states in the district. That was something that State Pharmacy Association execs were really interested in. How does my state compare to other states close by? In December, as a result of the task force meeting last November that Bill talked about earlier, we began providing these reports to the state boards of pharmacy through NABP. So each month, the California Board of Pharmacy gets the Wellbeing Index monthly report for District 8, and it includes, again, a slide like this. So this one shows that April and May, this happens to be the May report sample. In April and May, the distress percent for California didn't change. And the state was ranked 44th out of 52. And you're thinking 52, there aren't 52 states, but it's the 50 states, excuse me, DC and Puerto Rico. So that's why it's 52. 52 is the lowest distress percent. And you'll see that here in Wyoming. And so California is in that lower area of distress percent based on the states. I did pull yesterday the California numbers since this slide was created, and there was about a 0.25% decrease in the distress percent with increase in assessors to 602 and tick down one spot in the rankings to 45th, so trending towards one spot lower. Okay, next slide, please. So this document, this was also mentioned earlier, I believe, and it's the Pharmacist Fundamentals, Responsibilities, and Rights. This was developed in a collaboration with APHA and the National Alliance of State Pharmacy Associations, or NASPA. And it was released actually this time last year. Next slide, please. Bill talked a little bit about this. The pharmacist's fundamental responsibilities and rights is really two sets of principles that outline a pharmacist's responsibilities and then what they need to fulfill those responsibilities, and that would be the rights. And so these two sets of principles go hand in hand. You really can't have one without the other. You can't tell pharmacists you have to meet all your responsibilities and then not provide them the workplace or the environment that they need to fulfill those responsibilities. Or you can't say, I want all these responsibilities but then shirk your responsibility. Or I want all these rights, but shirk your responsibilities. So normally you would think rights and responsibilities rather than responsibilities and rights. But we thought it was really important to start with the responsibilities and then say, in order to meet these responsibilities, we need these things to happen, or the rights. We have recently added, did a call to national organizations, national associations to support the fundamentals, as we call it for short. And then we also went out to schools and colleges of pharmacy, to other organizations, and have put a tool online for organizations to express their support of the fundamentals. We have a couple state boards of pharmacy, we have individual pharmacies, we have lots of schools and colleges, and most of the national organization. If the California board would think about supporting them, can do it through the online mechanism or contact me directly for that support. Next slide, please. Bill referred to this in his presentation of one of the task force reports. In January of 2022, NABP released the task force report and that supported the fundamentals. And this was critical and a very powerful statement in the resolution that NABP adopted. And I encourage you to go look at the full resolution. This is one statement from the resolution that talked about what the pharmacists and patients and how the fundamentals are important to that. There is one caveat in their support in their statement, and I'm going to read it because otherwise I don't get it right. That their support included a recognition that certain provisions or certain principles of the document pertain to specific business models, and they may fall outside the regulatory purview of boards of pharmacy. And you discussed that a little bit earlier in your Q&A parts with Bill and with Bev. Next slide, please. Now we're going to go into more data, because as pharmacists, we love data. And we were told early on, APHA was told early on, when we would bring up the anecdotal reports about working conditions, they're like, yeah, where's the proof? Yeah, that's somebody's story, but we don't really believe this. We don't think there's any patient harm, and went on and on. So we set out and said, okay, you want data, you want proof, we'll do it. And so so these things were conducted in 2021 and early 2022. And I'm just going to do a few highlights of each. The full reports are all on the APHA website, and I believe Ann sent you links to all the reports. Next slide, please. The first one was the APHA NASPA National Pharmacy Workplace Survey. It was fielded in the summer and fall of 2021. And it was open. We promoted it and asked state associations to promote it as well. So it was promoted through periodicals, through social media platforms. And so that is a limitation of the survey, but the results or the findings match findings of so many other surveys and other vehicles that it's hard to ignore them and say, well, the limitation, only the people that were the most affected completed this. So, and we'll, the final report was released last fall. And these first 4 bullets here on this were the actual findings and conclusions of the study. Now, this study and final report is just touching the surface of all the data and findings in this survey. So the researchers that were helping APHA and NASPA with this are putting together a number of peer review papers for peer review that will get published in the pharmacy literature that will delve into specific areas that are of interest to the researchers, and because they're showing up so much in other areas, that we want to really delve into certain aspects in those peer-reviewed papers. But this report goes over the high-level findings that might be of interest to you all. One important thing that we learned, and you sort of touched on it earlier, a lot of the findings relate to systems-based issues, or what is happening in the pharmacy that may not be in the control of the pharmacist. And so that's an important finding in this particular study, and it's findings that you have identified through other surveys as well, I'm sure. Next slide, please. There's a few more findings, but the first one, I think early December, we got kind of a snapshot of the early findings, and we're shocked when we saw this first one, because it was really the first time we had heard from pharmacists and pharmacy technicians and student pharmacists that they were encountering harassing and bullying from patients, and that their employers were not necessarily supporting them stepping away from those situations. We have now heard this through the next thing that I'll talk about, the PWWR, that this is a real concern for pharmacists. And I believe someone asked this question, or maybe it was in one of the comments, that bullying and harassment from patients is real, and pharmacists are identifying that as a likely cause for medication errors. And so that's probably one that as a profession we could come together and address on how do we help pharmacists step away from those situations and train store managers, or even in hospitals, managers who aren't pharmacists, understand that the patient, the customer, is not always right in all situations, and bullying and harassing and unreasonable demands are contributors to the workplace environment that is causing such stress to our workforce. The last finding, that pharmacists don't feel valued by their employers, that leads to, it's a key factor in occupational burnout. And so I pulled out, in the next slide, please, some the responses to some questions that kind of talk about this feeling of feeling valued, not heard, wanting to engage with patients. And the folks that responded, the overwhelming majority to all these questions disagreed that these questions to this. So my employer actively seeks my opinion. 64% disagreed with that. That they were able to talk to their managers about issues that are impacting patient care, that channels of communication exist, that my employer respects and values my input. I think that these are ones that should be easy to address and could be addressed quickly. Opening lines for real communication, not just saying you're doing it, but you don't really mean it. It has to be a sincere communication or back and forth between the staff and managers or supervisors or hospital administrators. And as we've talked a lot about, it can't come with judgment or retribution. Pharmacists want to feel valued and heard. And so these are all issues that lead to occupational burnout. They're all potential risk factors. But this idea and need to be heard, and to be heard in a safe way, in a safe place, led to the next program, next slide please, that was developed by APHA and NASPA, and that's the Pharmacy Workplace and Wellbeing Reporting Service, PWWR, or we just call it POWER, the POWER tool. And so what is it exactly? Well, it's a safe space for pharmacists or pharmacy personnel to report their practice experiences, both positive and negative. It's not just to hear just negative, but positive and negative, in a secure online portal. And the reports, I don't have access to any of the individuals' reports of their experiences. They're collected and analyzed by a patient safety organization. And so it affords those reports all the legal confidentiality protections provided by the national PSO laws and regulations. The aggregate data from the report is provided to APHA and NASPA approximately each quarter, so that we can see trends, or we can see, are there things happening in pharmacy that need to be addressed and called out to the profession at large? What can we learn? Are people putting in their experiences and then what they did to try to correct those experiences, or to solutions for their negative experiences? Or what did they, what can we learn from positive experiences that are reported? But we're pretty excited that I thought it would take a long time to get folks comfortable in reporting. But since this was launched last October, with minimal promotion and marketing, if you will, of the service, we've received over 1,200 reports. The first 1,000 or so have been analyzed, and we're in the process of analyzing the ones that have come in since. The next slide, please. So the key takeaways from the first two reports: that harassment, here we go again, harassment of pharmacy personnel by patients and consumers is real. That communication, the two-way lines of communications are perceived not to be open, and that tracks back to the workplace survey. 71% of the folks that said they had, who had a negative experience, indicated that they offered a recommendation to their supervisor. But a majority of those 71%, so I don't have the actual numbers for you, also reported that their recommendations were neither considered or applied. We did learn from some of the verbatims that folks were not sure if they even read their recommendations, or if they even really heard their recommendations. And so those open lines, or the feelings of being valued and listened to and heard, are not happening. Were not happening at the time of these reports. There were a few positive experiences reported, and that's always good. And we learned that the folks that reported positive experiences said those positive experiences have a long-term positive effect on their well-being. And these weren't huge things. Like sometimes we think you have to do really enormous things to make a positive impact on a pharmacist or pharmacy personnel's workplace. Their positive reports included their manager or their supervisor checking in on them as an individual, not how's work going, but how are you, so that they really felt that they were valued by their employer because they were checking on me personally. They also found that if their employer asked them for their opinion on something before, like say before a new service was added, they asked their opinion about what did they think, how did they think that was going to work in their practice environment. Again, being valued for your opinion and listened to. And then the one that made me a little sad, that a positive experience report had to be submitted, but that they actually had time to take care of a patient, to really help their patients understand their medications. That should be a given. Personally, I believe that should be a given. But someone took the time to make that a positive report and said that that would dramatically improve a long-lasting effect on their well-being. Okay, next slide, please. APHA does pulse surveys every now and then. They are open for a very short period of time, a couple weeks. They're focused on a specific issue. and anyone can respond. This one was done in late 2021. Again, we heard, well, this is only happening because of COVID, and it didn't exist before COVID. And so these questions were asked, and wondering if anyone experienced these things before COVID or during the pandemic. And so, yes, there were things, a good between 50 and 25% responded that in fact they were experiencing some of these things pre-COVID, but the numbers really jumped during COVID. So as we said before, a lot of these issues existed before, but the pandemic has magnified them. Some of these that are listed here, the sense of dread and lack of enthusiasm, coupled with the feelings of being disinterested in talking to patients, interested in talking to patients, but they really can't connect. They don't want to go to work. Those are all hallmark indications of real occupational burnout. And I'm not talking about, I'm tired, I'm a little crispy today, but truly real occupational burnout that could cause potential harm in a patient, in a healthcare provider, the pharmacist personnel's lives, or have them leave the profession altogether. Okay, the next slide, please, which is quite busy. But we talked a lot about all the things that pharmacists have added during COVID on top of what they're currently doing. And when we talk about this, that pharmacists, they're ready, willing, and able, but they're really stressed and stretched. And so we'll get pushback occasionally from policymakers and regulators. Will say, well, then pharmacists shouldn't be doing all these immunizations if they're too busy. And that's not the answer. Pharmacists want to take care of their patients and provide these services, but there are a lot of things outside their purview, payment, policies, authority, all the interruptions and staffing shortages that really have stretched pharmacists almost to the breaking point when trying to provide these new things on top of what they're already doing. So all this data and outcomes that we got in the last quarter of 2021 and in the first month or so of 2022 led APHA to convene a stakeholder summit. Next slide, please. And Bill referred to this. This is the Community Pharmacy Workplace Summit. It brought together almost 50 stakeholders from corporate members to frontline pharmacists, to national associations interested in the subject matter. And it's really just the first of a series of summits that APHA hopes to host. We wanted to focus on community pharmacy first and then move to other practice settings to look at the workplace issues, because there are workplace issues in every practice setting that need to be reviewed, discussed, and addressed. So over a better part of a day and a half, they had really open discussion. There were no cell phones allowed. There were no laptops allowed. Everyone had to sign an NDA. So everyone felt safe as possible to discuss. None of the conversations were attributed in the report to any individual, so that people really felt safe to have that frank, open, and honest discussion, because really that's the only way that you can maybe come up with solutions. So these are the bright ideas. We called them bright ideas from the summit. And they're probably not things that are shocking to any of you. You've probably say, yep, we should do that. Yep, we should do that. But it was good to have this group come together and say, these are really the important things that as a profession, we need to look at. But many of these findings, these bright ideas, all track back to the workplace survey, the power reports, and the fundamentals documents. And at the next slide, I believe Ann sent you this link too, but the summit report's also available on the APHA website. And next slide. I went through that really fast, so I'm sure you all have questions or comments. One thing, you talked a lot about staffing and why people are leaving. The Pharmacy Workforce Center, which is a separate organization but housed at AACP. So if you Google Pharmacy Workforce Center, they do pharmacist demand reports every quarter, but they also sponsor surveys that get to some of the reasons why pharmacists might leave or are leaving. The last one was conducted in 2019. That survey's results are on, I think, or maybe it was 2018, but pre-pandemic, is on the PwC website and might be a good resource for you all for the time being until you can conduct something that's specific to California. And I thank you very much for asking me here. I'm sorry if I went too fast, but it's been a long afternoon for all of you so far. And I hope that this helps the committee as it continues its really valuable work in this area. I appreciate it.
Thank you, Ms. Shaughnessy, for coming today and for reminding us that some of the challenges faced by pharmacists existed prior to the COVID-19 pandemic, though I think the data provided does highlight the significant impact that the pandemic has had on our profession. I found it interesting that something as simple as regularly checking on staff and asking for input from staff have a long-term positive effect on well-being. I also appreciate the responsibilities and rights document developed. Many of these responsibilities and rights are directly related to the work of our committee. So I'm going to ask Vice Chair O if you would please facilitate member comments in Sacramento.
Sure, thank you, Chair Tebow. Go ahead, Kula.
April, thank you so much for your presentation. As we've heard a lot today, there's a couple of things. One of the commenters talked about this being a business model problem, and I'm hoping that as a committee we can kind of talk through that a little bit more. And I think you talked about it being this is a systems-based issue, and a lot of things are not in the control of the pharmacy staff. And so I think, again, that's another thing that this committee needs to think through. Some of the, changing systems takes a long time, but there's things that we can, do, at least I think sooner rather than later. And some of those things that, I was thinking just even like PR campaigns, because what you said about not feeling valued by their employers, and the data also show they're not valued by the public. In terms of, that bullying, and, President O talked about people who are flying airplanes and nurses. And I think the difference is the perception that if a pilot, isn't doing well, is in distress, your life is in that pilot's hands. Same thing with a nurse. But for whatever reason, that's not the same thought process that's given regarding a pharmacist, somebody who's dispensing you medication. So I think that we need to really that's some of the things that we can do maybe sooner rather than later around, I remember even driving and seeing campaigns around construction workers that they would be like, hey, slow down, my mom works here, to like really think there are people behind here. So anyways, just some things that are in my head, and I just really thank you for your presentation, and I hope that, I did have a question. Can you share why Wyoming is so low? Is it because it's more of a rural location in terms of the dissatisfaction?
We don't know why. It's just the assessors, and it is more rural. They just, I'm in Omaha, Nebraska, and Nebraska's has been rather low. It's been ticking up a little bit lately, though. And I asked the folks at Nebraska Pharmacists Association, why do you think you're so much lower? Is it because it's kind of a Midwest thing? You just take everything in stride, you just go, and so you don't, or what is it? And no one really had a response for it. We don't get that kind of information. One of the questions, an optional question that's in the Wellbeing Index is, what could APHA do? And we've gotten over 3,000 responses to that question from assessors. And they range from everything to, you should do this kind of legislation. Lots of them saying, please work with boards of pharmacy, help us. To, we just need some better training on how to reduce stress in the moment at the workplace. So some of those are kind of telling us why maybe the distress percents are higher or lower in areas. I'm going to pull them based on the states and provide them back to the states in the next couple of months, because I think they can learn a lot from what their assessors are telling us. But I don't have a reason why Wyoming has been the lowest for the whole 3 years. We launched it in 2019, in July of 2019, and Wyoming has been the lowest with the exception of maybe 3 or 4 months in the 3 years. So it might just be because of the rural nature, but we don't know that for sure.
Thank you, Kula. Jesse?
Thank you so much for all of this information. I'm still kind of digesting everything, but it's
a lot.
It's really amazing and also saddening as well to see, what our fellow colleagues are going through. Also touching upon what Kula mentioned with pharmacists feeling threatened or being harassed, I can say that I've personally experienced that. I've had to file police reports against patients who have threatened to follow me or physically harm me. I've been removed from stores because of it. I often find that it's connected to a refusal to fill a controlled substance.
Right.
And after talking to several colleagues across different pharmacy chains, a lot of pharmacists end up resorting to lying to patients about whether or not to have something in stock as a way to protect themselves and so that they're not putting themselves in harm's way. So I just wanted to note that, because I'm not sure if that's ever been brought to the board's attention. And in my experience as a PIC, I've also had to step in where some of my technicians have been harassed with homophobic or racist remarks, and I've had to actually ban patients from stores because of it. But I don't necessarily see that always happening. I've actually had former technicians call me crying because it hadn't been done with the, newer management in place, and it's sad to see that happening. And I've also been unsupported by my management in scenarios where I did use clinical judgment and refused to fill controlled substances. And a lot of times what ends up happening is it's kind of spun into a customer service complaint. Rather than using the professional judgment. So I do feel like there is an area in which non-pharmacy management may be overstepping boundaries and putting pressure on pharmacists to fill prescriptions that they don't feel comfortable filling. So that's just a kind of perspective. I don't have any questions, but I'm very happy for all of the work that you're putting into this, and I look forward to seeing what other work comes out of this. Thank you.
Welcome. The Wellbeing Steering Committee at APHA will be exploring the role of the PIC. We've heard anecdotally that state regulations require the PIC to be in charge, but they're not. If they're not in in their own store pharmacy. So what does that really mean? And that is something the board can look at as far as are the PICs really in charge of the pharmacy? And so you would be then supported if you stepped in to help one of the pharmacy staff members who is being bullying or harassed or whatever that might be called in a particular state. Something else, there is a national report that will be released on Friday from the National Academy of Medicine. It's a national action plan to address healthcare workers' burnout. Unfortunately, the word pharmacist and pharmacy are not mentioned in the report, but the principles can be applied to pharmacy practice. So I alert the board, your committee to maybe look at that report when it's released on Friday afternoon. Well, it would be Friday morning for you guys. That there might be some interesting information in that report that you can use in your work on this committee.
Thank you, April. Well, to just add to Kula's comments, I myself was told a few times that you just need to put some pills in the bottle. Why can't I just go? Why is it taking so long? Many times, so I understand that we do probably need to do some, I don't know, better job or what we need, I'm not sure. But so with this research, this is great. I thank you so much for your work. I'm just curious on what APHA, it's such a hard thing to do as a national organization because I think our pharmacy regulations are so state specific. Like I see here your kind of next steps, but are there something substantial that could hopefully help us bring upon some changes that may be necessary to actually make changes?
We've had discussions with operations folks at the national level about the findings the preliminary findings from the workforce study. We specifically brought up the patient bullying one because that would be something that they could address and really help their pharmacists. And we asked, you do training for robberies or active shooters? Do you do any training to help your pharmacists or pharmacy staff and your store managers de-escalate a consumer or patient who's really harassing and bullying the staff? And these aren't necessarily, controlled substance prescriptions. These were their everyday patients that were just, they were in the same state as we all were in the height of the pandemic. So they said, no, we don't, but we could easily do that. So a lot of it is bringing all this data into digestible chunks to those in operations to talk with them and really have those open and honest and frank discussions about what we're seeing. And so when someone says, I can't find any pharmacists for all the positions, we're offering them all this money. And then we said, yeah, but are you addressing all these workplace issues that we're finding in all our surveys and the power reports and everything that we're doing that research-wise or in talking with our members, are you doing anything to address these situations? And maybe that's why you're having a hard time filling positions. Yes, we're doing all that. So it's for APHA and national organizations and even state pharmacy associations is constantly having those conversations and showing the quantitative data along with the verbatims and qualitative reports that we're getting and anecdotal reports, and just constantly showing them that to say, here's some things you can address. And some of these aren't really big things that you should be able to do these kind of easily. Ask your staff how they're doing, really value their opinion, really, and being sincere about it. So we're going to have more conversations and just keep it in the periodicals of APHA and on social media and respond when we see things, applaud organizations or that are doing things that might be of help, spotlight those, and then also talk about things that aren't going well. Because it's affecting applications to pharmacy schools, especially the negative consumer press, and it's affecting student pharmacists' desire to take care of patients in the community setting. So it's not really a very good answer for you. I'm sorry.
No, that's okay. Thank you,
Keep
April.
working on it.
Yes, thank you so much, and hopefully you'll stay on with us and trying to continue on and let us know what's going on with APHA throughout our journey here in California.
Absolutely. And you'll get those monthly reports so that for some things to track and look at. And as new reports or published studies come, I'll remember to send those to Anne for you.
Thank you. Okay. And no. Okay, we'll take it back to you, Chair Tebow. Thank you, April, so much.
You're welcome.
Great. Thank you so much. That was a really great discussion as always. This committee is great. I love getting to do this. Jesse, you're super valuable in your comments. Love having you here. April, one thing I just wanted to flag, I don't know if this is something APHA is already doing. I think as an industry, pharmacy does not do a great job, at least at this point, in looking at diversity and the way that these, we're seeing all these negative outcomes, but how are they different for different marginalized groups? So are we looking at, are these levels the same for women versus men, for people of color, for members of the LGBTQ community? Because when you add those, multiple intersectional levels of marginalization, I have to wonder if the results get worse. I would assume that they do. And I don't think we have look at that a lot in our industry. And I think that would be really helpful to bring going forward as we can.
Two things. APHA does have a DEI committee or task force that is looking at issues and reporting out as they find things to report out. But it came up in both power reports, and our the person that analyzes the reports at the PSO said it's not a trend yet, but it's something we should look at. And is that the harassment and bullying by coworkers and patients is higher for females and persons of color. And so we're going to watch that over time to see if we continue to get reports in that area, or if those happen to be the reports we got in those two periods. So he cautioned to say, I can't say it's a trend, but it's something that we are going to watch. Great. And having practiced a long time ago, I understand that the bullying and harassment from being a female in the pharmacy, especially back when I practiced, it was a long time ago.
Yeah. I would love to see us think about adding sexual orientation and gender identity to that. I know LGBTQ+ doesn't often get categorized in the data pulled separately, but if that's something we have the capacity for, I think that would be really valuable.
We don't in the well-being index yet, but I can explore that for to see if we can make that kind of change in the demographics that we pull for that.
Yeah, that would be great. It would put us at the forefront as an industry if we were working on that. So so at this point, we're going to open it up for public comment. As we don't have any in-person public, we are going to have the moderator open it up for people on Webex.
Thank you, Madam Chair. I've opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. And I see that Lonnie Dawn would like to make a comment. So Lonnie, you should be able to unmute yourself. There you go.
Hi again. Thank you so much. I'm really grateful for all of the presentations today, and specifically the one that was just presented to us. Three things. One was that I wanted to ask if the power data can be stratified by, chain versus independent pharmacies, and if there might be any differences there. And also, do we know what percentage of responses, per state versus their population? If that data is available, only because that could also impact, the state rankings. I'm happy to hear that California ranks, low for high risk for duress, but I also don't want that to minimize, those of us that are having, that are in high duress. And so, and I think you did a really great job of presenting that information in that way. So I want to thank you for that. But just as an example, I think California was about 29% at risk of high duress, but with a state that has 40,000 pharmacists, 30% is still 12,000 individuals, people, pharmacists that are at risk for, leaving their workplace, having high burnout, and having, like you had mentioned, twice the risk of a medication error. So that's all I have. Thank you so much.
You're welcome. Just to clarify, you can't extrapolate the data from the well-being index to the general population. It's 30% of those who assessed. So
Yes.
you can't really say that it's 30% of all pharmacists in California,
Yeah.
but it is a snapshot in time, and it's a marker that can be tracked over time. And maybe more specific or focused research in California is something that this committee or the board could do. So just be careful about extrapolating that out to the full population.
Yes, thank you for that distinction. I appreciate that.
Sure.
All right, this is a moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you.
You're welcome.
Ms. Shaughnessy, thank you again for your presentation. And
you're welcome.
As a committee, we will continue to monitor the monthly well-being index reports, and we'll continue to monitor the activities of APHA. Related to this, I wanted to ask Board of Pharmacy staff, could we include information on the well-being index like as a way to promote its use for pharmacists in California? Or can I make that request?
Yeah, I think we could look to potentially include something maybe in our newsletter and maybe the link so that pharmacists are aware of the tool and could maybe avail themselves of it. And then perhaps, if pharmacists do that, then we'll have additional data that then we as a committee and the board would receive on a monthly basis. So I think that that's definitely something we could do. It feels like the newsletter may be the best place for that, but I'll, defer to members to see if there's somewhere else. People generally, I think, have a pretty good read on our newsletter.
That sounds great. Other members, did you have any thoughts on where that should go?
No, I think the newsletter's good. Hopefully the website.
Mm-hmm.
Thank you,
great.
Nicole.
Thank you. All right, and with that, we are on to agenda item 7, future committee meeting dates. Member, our next meeting is scheduled for September 14th, 2022. As we continue our assessment of the issues as part of our meeting in September, I hope to learn about actions underway by other states' Board of Pharmacy. We will continue to monitor the activities of several organizations, including the NABP and APHA, and report back as appropriate. Thank you all for your time and attention today, and please stay safe.
Thank you. Thank you, Nicole. Thank you, everyone.
Thank you.